Ladies and gentlemen, I would like to thank the committee to permit me to present an update on Cryofibrinogenemias. My conflict of interest, my only conflict is of language. Cryofibrinogen was first identified in 1955. It is always composed of fibrinogen, fibrin, fibronectin, and factor VIII. It can also contain albumin, alpha-1 antitrypsin, beta-2 macroglobulin, and immunoglobulins. The difference between cryofibrinogen and cryoglobulin is that cryofibrinogen precipitates only in plasma and not in sera. You need to use a different tube that contains an anticoagulant, except heparin, because there is a risk of false positive result. So the detection cannot be done on the same tube for CF and CJ. The complement is within normal range in patients with cryofibrinogen. The exact pathogenesis is not fully elucidated. The main explanation is a defect in a fibrinolytic process. In these patients, high plasma levels of alpha-1 antitrypsin and beta-2 macroglobulin and delayed lysis time of globulin has been observed. We think that therefore there is an inhibition of plasmid, an inhibition of fibrinolysis, an accumulation of CF that clots with thrombin and leads to thrombotic occlusions. In these patients, it has been also observed increased thrombin binding capacity and clot formation, and fibronectin, that is a component of CF, can interact with circulating immunoglobulins or immune complexes that can be excessively produced during pathological conditions such as autoimmune disease or cancer. In healthy subjects, you can find cryofibrinogen in up to 7% of healthy people. In a patient in hospital, you can find about 10% of patients with CF. But when you are looking for CF in patients with suspected cryopathy, you can find up to half of them positive. There is two different things about cryofibrinogenemia. You can have cryofibrinogen as a marker in a patient without clinical vasculopathy, and you can have a disease that is called cryofibrinogenemia in the literature, but that I personally call cryofibrinogenemic vasculopathy to distinguish the disease and the marker in a patient who have cryofibrinogen in the blood but without vasculopathy. The clinical features are mostly the skin involvement with purpura, livedo, Raynaud phenomenon, and severe manifestation with ulceration or necrosis. Patients can have rheumatic involvement, peripheral nerve involvement, and renal involvement, but they also have very frequently thrombotic events. So the clinical features are very similar to cryoglobulinemia vasculitis and other vasculitis. Cryofibrinogenemic vasculopathy is either primary, and there is a risk of lymphoma in this population. In the only studies that observed people with primary cryofibrinogenemia, that was published by Christina Belizna, half of the patients during the 5 years follow-up had lymphoma. Cryofibrinogenemia can be secondary to autoimmune disease, vasculitis, cancers, and infection. There is no established diagnosis criteria for cryofibrinogenemic vasculopathy, but we think that detection of cryofibrinogenemia is essential, as well as the compatible histology. And regardless the anatomic site, you can find vascular occlusion by CF that are eosinophilic refractile deposit within vessel lumina and extension to the antima. There can be inflammation, granulomatous vasculitis, leukocytoclastic vasculitis, and necrosis. The treatment of secondary cryofibrinogenemia is the treatment of the associated disease. In patients with primary cryofibrinogenemia, avoidance of exposure to cold can be sufficient if they have a mild manifestation. In patients with moderate and severe manifestation, you can use corticosteroid and/or immunosuppressive therapy. Plasmapheresis can be efficient in a patient with severe manifestation, as well as the use of fibrinolytic agents such as alteplase or streptokinase. Stanozolol can also be used because that is a fibrinolysis enhancing effect. It can be used as a maintenance therapy in moderate form, but there is side effect and action that is delayed. Remission is achieved in the majority of patients, but with frequent relapses. Anticoagulants are only used in case of thrombosis. So we saw cryofibrinogen as a disease and as a marker. Different studies in kidney disease have been performed. In patients with immunoglobulin A nephropathy, Nagy et al. Found frequently cryofibrinogen, and there was no remission in patients during the follow-up if cryofibrinogenemia persisted in their blood. And there are more severe vascular involvement on the renal biopsy. Benjamin Terrier studied 101 consecutive patients in the nephrology department. 11 of them had cryofibrinogenemia, and there was no difference between patients with or without cryofibrinogen, except for the frequency of thrombotic events, and they occurred in 1/3 of the patients with CF. In patients with inflammatory bowel disease, CF was more frequently found and with higher level in acute disease compared to remitted disease, and was correlated with level of ASR. In patients with non-traumatic osteonecrosis, patients who had multifocal osteonecrosis at higher levels of cryofibrinogen. In primary renal phenomenon, cryofibrinogen has been found in 80% of the patients, and it also be found frequently in dermatitis hepatiformis, and more frequently in untreated patients, but it had no clinical consequence. To finish, cryofibrinogen is very frequently associated with cryoglobulinemia. And in HCV, patients who have cryofibrinogen have more frequently vasculitis. We found the same result in patients with non-HCV vasculitis. And CF was the only factor independently associated with the use of the most intensive treatment. And we found that cancer was more frequent in this population, as well as in patients with cryoglobulinemia without clinical vasculitis. So when you ask for research of cryoglobulin, you may also test for cryofibrinogen in the same time, because the clinical manifestations are similar, that it is underdiagnosed, and it has specific features with thrombotic events, complement in normal range, and specific findings on biopsy. Patients have the risk of lymphoma. And to conclude, cryofibrinogen as a marker is probably a marker of more severe disease. It's more a consequence than a cause, because more severe disease has probably a fibrinolysis defect that creates cryofibrinogen. Association with cancer is very important, and we should be careful in this patient, but we need additional studies, especially prospective studies.